Hello, good morning, everybody. Please, if you can have seat so that we can start our next session. My name is Dr. Zishan Tariq. I'm one of the medical oncologists at Shaukat Khanum, and I'll be conducting a breast cancer session for our 23rd Shaukat Khanum Cancer Symposium. I would like to welcome you all for this symposium. And who is the chair? Uh, so I would like to invite Dr. Azhar Shafi, who is a medical oncologist at Shifa International Hospital, and he's also assistant professor there at faculty. So if you can come up, Dr. Azhar, thank you very much.
Assalamu alaikum. In the interest of time, I'll just start. Thank you so much for the scientific committee for inviting me. It's a great honor and pleasure to be back at Shaukat Khanum from where I did my fellowship. And I'm so happy to see a lot of my colleagues there. So I have no conflict of interest. And the basic theme of my talk is early stage HER2 positive breast cancer. Where are we now and where are we going? What's the future? This is I like to share this as a proposed strategy for early stage HER2 positive breast cancer. As we know, if we have patients who are low risk, which we get very few, I would share it with you, like T1 and not, and or if the patient desires surgery, or if the surgeons desire surgery. So we take them directly to surgery. Otherwise, the standard of care is all high risk, T2 or node positive. We should be giving them new adjuvant, single or double HER2 new blockade with chemotherapy. And the reason I'll explain later that we are so much interested in future about the pathological CR. We'll go into details about this and the uncertainties we are facing now. As we see, HER2 positive breast cancer, especially early HER2 positive breast cancer, has seen a continuous improvement in patient outcomes, starting from chemotherapy, addition of trastuzumab, then the double blockade with pertuzumab, then add-on niratinib, and for the residual disease, TDM. So, couple of questions to ask first. Can we de-escalate, or the conventional thought can do away with anthracycline? And the answer is yes, and we have a good support by trial BCI RG006, 10.3 years follow-up. So clearly shows that even in the high-risk group, you do not have a survival advantage of using anthracycline, and TCH is good enough with less incidence of secondary leukemia and less cardiotoxic. So yes, you can safely omit if you are giving trastuzumab. Can we substitute anthracycline with a taxane? TRAIN2 trial. And again, the answer is yes. It's almost the basic concept is the same. That the PCR, even without anthracyclines, was the same in across all subgroups. More patients in trastuzumab like anthracycline-free arm completed treatment, and more febrile neutropenia in the anthracycline arm. As we understand, there is less cardiotoxicity and leukemia. Can we substitute taxanes even with TDM? And we have Christine trial comparing conventional TCHP with TDM with pertuzumab. And then we follow up. Interestingly, the pathological CR is inferior with TDM with pertuzumab, but if we look at the 3 years IDFS, it's essentially the same. If you are using TCHP or TDM plus Perjeta, no difference in IDFS. So it's not really easy to answer that question, especially in our setup. TDM is quite costly, and we barely use it for patients who have residual disease. So definitely the inferior rate of PCR is compared to TCHP, but the IDF is the same. It can be a reasonable alternate in patients who without HER2 heterogeneity or low HER2 expression, but more data is needed to confirm that. It's unclear if pertuzumab is adding much to the TDM, but again, we need more data on this. Can we de-escalate chemotherapy? And we have this phase 2 study, and we have 10 years follow-up of this APT, in which we used only paclitaxel weekly for 12 weeks with her trastuzumab, followed by 1 year of trastuzumab. And we have a decent 10 years data of 91% IDFS and 96% recurrence-free interval, which is very decent, especially for low risk group. This is node negative, ER either positive or negative, and less than 3 centimeters, a low risk group. And another question, sorry for the slide. Does TDM have a role alone, has a role for early stage disease? So these trials are aimed at like, can we decrease the toxicity of chemotherapy, especially hair loss, alopecia? So this is again the same subgroup, early stage breast cancer, and not or microscopic only. TDM, it's important to know TDM was given for the whole year alone, 17 cycles. And then the other arm is, of course, paclitaxel and Herceptin. And we have decent 5-year IVDFS of 97% and RFI of 98%. And of course, a better quality of life if we look at it, less alopecia in the TDM arm. But because most likely the TDM was given for the whole 1 year, no difference seen in the overall incidence of clinically relevant toxicities between the two arms. Of course, as we know, TDM as compared to the taxanes is associated with less risk of neuropathy, better work productivity, and less alopecia. And it may be a good choice for patients who are very concerned about, as our patients are, about alopecia, neuropathy. A lot of our patients, even who are not diabetics, would get neuropathy with taxanes. So they can be potential candidates for this. But as we know that we have to educate our patients about the TDM side effects as well. Marked thrombocytopenia, elevated liver enzymes. So can we do better than this? So this is another trial. This is an ongoing study, in fact, attempt 2. So this is basically looking at, can we use less cycles of TDM and do better? So in this, TDM was used only for 6 cycles, followed by subcutaneous Herceptin to complete 1 year. And the other arm is the same TH arm. And this is, we don't have the results of this, but hopefully this can answer another question. So this is an area of conflict about guidelines are not really very clear because we do not have any randomized data. Especially if we look at that, the small T1A and T1B node negative tumors. As we know, most of the trials excluded, like they either the number is less or the trials did not have a significant number of these patients. So we do not have a randomized data to suggest to do what. And just look at the NCCN as well. This is 2024 version. And not consider endocrine therapy or adjuvant chemotherapy with trastuzumab or endocrine therapy alone. Microscopic, again, same recommendation. And the reason is, as I've mentioned. So can we come up with a potential answer for this uncertainty? The reason is head-to-head HER2 positive small tumors, the risk of recurrence is quite high as compared to HER2 negative. So is there a tool we have now or we can use in future which will help us make a decision? And the answer is yes, we have it now. and I'll discuss it in the later part of presentation, is this is a genomic assay, which we have developed now and we can apply. This is HER2-DX, which I'll be explaining in the later part of my presentation. So next question, what is the impact by reducing the duration of trastuzumab? As we know, currently the standard of care as recommended by guidelines is 1 year of trastuzumab. And we have a non-inferiority RCTs of it's about 5 randomized trial with 11,389 patients, in which the shorter version, as compared to the longer version, the shorter version, you have better IDFS and overall small survival benefit. So the standard of care remains 1 year. Although we know now with emerging tools that there may be a subset of patients we can probably safely de-escalate, but not now. Right now, the standard of care remains 1 year. Because now the treatment options are emerging, we are using now Herceptin Perjeta combination. Then for the residual disease, we are using TDM. This data is not applicable for all this. So currently, the standard of care remains the same. So the new adjuvant, a word about the new adjuvant approach for the slightly high risk tumors, stage 2, stage 3, node positive, more than T2. So one of the difficulties we have as physicians is, as you see, there is a knife, keeping the knife away from the patient. So high-risk patients ideally should get a biopsy, and then we should be planning neoadjuvant treatment. As we know that we are so much focused on the outcome of neoadjuvant treatment, whether the patient gets a pathological complete response or have residual disease, and the sort of residual disease patient gets. Should we de-escalate or escalate? So it's important. And now we have fair data suggesting that the dual HER2 blockade combined with chemotherapy gives us a decent PCR from the range of 40% to 63 in different trials. Like the conventional, now we are using most TCHP6 gives us a pathological response of around 63%. So another question, can we increase the efficacy of adjuvant trastuzumab? And the answer is yes. If we combined it, we have the data from affinity trial combining Herceptin Perjeta, and it does give us IDFS benefit in patients who are node positive. There is no overall survival benefit at not even at 8.4 years follow-up. So when we should give pertuzumab, as we know we have resource constraints, pertuzumab has toxicity, it can cause diarrhea, it costs a lot. So most probably in patients who are node positive or more than 2 centimeter. Just a word about neratinib. As we know, it's a tyrosine kinase inhibitor and a tough drug to give with a lot of grade 4, grade 3 diarrhea. So this is a subgroup of patients who had either high-risk group or a residual disease. And in the FAB 2010, they restricted patients to who were node positive only. So the basic benefit of neratinib was in patients who had residual disease with absolute IDFS as well as OS survival benefit. But neratinib giving for 1 year is quite tough. It has got lots of diarrhea, and there's a significant number of patients who cannot tolerate this. So word about residual disease. As we know, we had this phase 3 study of adjuvant TDM versus trastuzumab for residual disease already published and presented at St. Antonius meeting last year. In the Catherine trial, after surgery, we randomized patient to trastuzumab versus TDM, and similar baseline characteristics. Catherine IDFS of 13.7 benefit at 7 years and overall survival benefit as well. So this is quite clear that it does give us IDFS and overall survival benefit. But is there any need for improvement? Are we lacking something? No real benefit in the rate of CNS recurrence, even if you give TDM. And 3 years IDFS is 83%. So what do we do? Can we escalate? Yes. So we have a trial ongoing, Destiny 5, in which one arm has just TDM and the second is TDXD, replacing Herceptin with TDXD. And the add-on strategy, the compass to trial, just to simplify, is one arm is TDM and the other arm is adding tucatinib. So add-on. And another escalation trial is, this is going beyond triple negative, addition of immunotherapy backbone, atezolizumab to TDM in patients who have residual disease. This is currently enrolling and we have the early results in 2026. So what do we need in future? Can we spare patients from toxicity based on the current tools we have, and what tools do we have? Number one, can we use PET as a response criteria to de-escalate treatment and spare them from toxicity? And we have data from the FAGAN study in which early HER2 positive patients were randomized to two arms. One, the patient had PET CT and MRI of breast and biopsy. Arm A, TCHP 6 cycles, and arm B, just FESGO, Herceptin Perjecta, and PET response. And the patient who had PET response, and the response is, if you have S2 Vmax reduction of more than 40%, you keep on giving them another 6 cycles of FESGO and then go for surgery. And after surgery, if the patient in the FESGO arm have pathological complete response, you do not give them any chemotherapy and you continue with FESGO, like Herceptin Perjecta combination. So this is a subgroup of patients who can be spared from surgery. So if we look at this, the PET responders were 79%, and out of 79% PET responders, 1/3 patients had pathological CR. And we have 3 years IDFS and overall survival, which is identical to the chemotherapy arm. So we have now early data from this trial that there is a subgroup of patients we can spare from chemotherapy. Next one is this PET-based response. There's another study which I did not include because of sake of time, is MRI-based response. It's a Dutch trial currently recruiting patient based on the concept is the same, but just they are using MRI. Again, can we use biomarker assays upfront to tailor therapy? And the answer is potentially yes. So HER2-DX basically is a genomic assay which is based on expression of 27 genes, and which includes 2 anatomical features, tumor stage and nodal stage, and 4 immune signatures: immune signature, HER2 amplification, luminal, and proliferation. And it gives you, so what information, this assay has been developed after 10 years of research. We have it now. So it gives you 2 basic type of information. One is a recurrence score, especially in early stage breast cancer, is going to tell that what is the risk of recurrence. And as I mentioned earlier, we can use this information in our patients who have early breast cancer, HER2 positive, and we do not have any good evidence to do what? Like T1A, T1B. Second, it gives you a predicted pathological response rate. What is the predicted pathological response rate to a certain category? And it has been validated. Like if you look at this, it has been validated in the DEFIN trial in which 80 patients were treated with THP. And the patient who had HER2-DX PCR score, PCR probability score high, 92% patients had pathological CR. So another food for thought for de-escalation. Maybe we can de-escalate that. So HER2-DX is a very important genomic assay, which I think, trials, so far it has been validated retrospectively in different trials. One trial I've mentioned, this is different trial, and it has been also retrospectively validated on the APT trial, the TH trial from Dana-Farber. So what is the future? Can we select therapy based upfront on a biomarker response in our stage 2, 3 HER2 positive breast cancers based on HER2 DX score? Like, if we know that if the probability of pathological CR is high, maybe we can offer them less chemotherapy, even in stage 2, 3, like just THP 4 cycles or medium 6 cycles. Or if the probability is low, why not give them TDX from up front? If we know beforehand, rather than giving them something and we end up not getting a PCR. But these are all foods for thought for the future to be validated in the retrospective trials. So far, the HER2 DX assay has been validated retrospectively. So thank you so much for patient listening. And if you have time, do visit this place. This is in Pakistan. If anybody can guess. Fairy Meadows, 2 hours, Bial Camp. Thank you so much.
Thank you very much, Dr. Adil Shafi, for such a wonderful presentation. I would like to invite Dr. Amjad Zafar, who is chairing our session for breast cancer today. Unfortunately, he was not here due to some technical issues 20 minutes ago. So if you can please join us. He's assistant professor at Jinnah Hospital, and he's also visiting consultant at Hamiluddin Hospital, as well as PKLI, and he has multiple research papers under his name. So please welcome Dr. Amjad Zafar. Thank you. And Dr. Amjad happens to be our next presenter also. So if you can come to the podium for your presentation, that will be on current treatment options for early stage receptor positive breast cancer. Thank you.
Assalamu alaikum ji, and I think it's almost afternoon. Thank you to the organizers for giving me this opportunity. And frankly, when I was given this topic, I just thought it had to be either the chemotherapy or the hormonal therapy, which I had to address. But later I was told that it would be both. I would be covering in the ER positive breast cancer. So that is why I'm going to have a lot of slides, and I'm frankly going to skim through them. So please bear with me. So we all know that in ER positive breast, we all know that majority of the patients, if breast cancer have ER positive disease, and there are only around 20 to 30% of the breast cancer patients who are HER2 positive. So, and it has historically been thought and proven that ER positive tumors and the patient with those tumors tend to do well if they present in the early stages. But are patients of all the patients of ER positive disease candidates for chemotherapy, or can we just go with hormonal therapy? Well, the answer is with these tools, and we use many of them, but the most common one and the most established one is probably Oncotype DX. I mean, this is a 21 gene recurrence scores, and it has improved and been validated over different trials over the number of years. It all started with the validation in the B14 trial results. There were 3 subgroups, the low risk groups and the high risk group and the intermediate risk group. And it was thought that the patients who had low risk disease tend to do well with the hormonal therapy alone, whereas the patients with the high risk group, they tend to fare well with chemotherapy as well as the hormonal therapy. What about the middle group, intermediate risk group? Then there is a lot of discussion previously, and the discussion continues even now. The next trial which validated these results was the TAILORx, the famous TAILORx trial, in which we again ended up with 3 subgroups: the low risk, the intermediate risk, and the high risk. Though, I mean, it also substantiates the same belief that in early stage HER2 positive breast cancer, you can give hormonal therapy alone to the low risk group, usually less than 15 or less than 10. And with the high-risk group, which was more than 25%, the score was more than 25. I mean, they needed both chemotherapy and hormonal therapy. But the group with 15 to 25, that score, I mean, it was found out in this trial that if you give them chemotherapy, if they're younger than 50 years of age, or 45 years of age, or less than 35 years of age, if they were younger, if the subgroup of patient was younger, then they would benefit more from chemotherapy in the intermediate subgroup. But the problem was that in this subgroup of patients, we also gave ovarian function suppression. So whether the benefit was from the chemotherapy or from the ovarian function suppression, that is yet to be decided. I mean, these two trials had patients with ER-PR positive early stage breast cancer disease with no lymph node involvement. But our exponder trial had patients with involvement of axilla from 1 to 3 lymph nodes. It also ended up giving us the same answers, that the patients with high-risk group indeed benefited from chemotherapy along with hormonal therapy, where there was the low risk subgroup, they benefit a lot from hormonal therapy alone. So this is an algorithm which we tend to follow usually. I'm the low risk group, less than 10, just the chemotherapy alone. High risk group, more than 25, you give both. And in the intermediate risk group, if the age is less than 50, you tend to give them the benefit of the doubt and give them chemotherapy. And if the age is above 50 years of age, you sometimes do not give them chemotherapy at all. But in some patients, if we give adjuvant hormonal therapy alone, so is it sufficient? Do we have enough data? Where did the adjuvant hormonal therapy idea came from? Well, it started in the 1960s, where Dr. Walpole and Richardson developed tamoxifen as the morning after pill, and it developed from there. In the early 1977, I think we got the approval for tamoxifen, then it was followed by anastrozole in 95, letrozole in 97, and fulvestrant finally in 2010. There have been few drugs, but not that effective after 2010. But does the story end here? Do you have enough data to use adjuvant tamoxifen alone? Well, we have a plethora of trials, but the two famous ones which showed improvement in overall survival were the NATO and the Scottish trial with significant p-value. AIs in the adjuvant setting, I mean, we all know the benefit more in the postmenopausal women subgroup, but they also tend to have a benefit in a lot of patients in premenopausal subgroup, especially if they're used with ovarian function suppression. Do we have data? Definitely, yes. MS17, ATAC, big. I mean, there are lots of trials, but these are the ATAC and big 198. These are the ones which show that they increase the overall survival as well. And no discussion on hormonal therapy adjuvant setting can be complete without these two trials. Which ones? I mean, the SOFT and the TRAX trial. What they did was 3 amps. One was TAM alone. The second was AI plus ovarian function suppression. And then the TAM plus ovarian function suppression arms. They were combined together, and the data showed that if you used ovarian function suppression with AIs, I mean, the effect of the chemotherapy, hormonal therapy tend to be better as compared to either using TAM alone or AIs alone. I mean, even the 13 years follow-up also showed this benefit, but it also showed that if you use ovarian function suppression with AIs, the benefit was more enhanced, especially in the population which was young, less than 35 years of age, and who had a bit of aggressive tumors. Optimal duration, I mean, the discussion has been going on for the past 2-3 decades. TAM first was given for 1 year, then it was for 2 years, then tamoxifen 5-year data came up. EBC, early breast cancer trialist group, what they showed was that if you use TAM for 5 years, the data is much more, I mean, the TAM is much more beneficial, almost twice as much beneficial if you use it to 2 years. But we all know that it does not stop there. Now, there is a lot of data which tells you that hormonal therapies, both AIs and TAM, can be used for more than 5 years, 7 years or 10 years, your bet, different trials, Atlas, Atom, to name a few. I mean, you can see Nanas Baby B33 and a lot of trials here, which can tell you that you should use rather the hormonal therapy for 5 to 10 years at least. Now there is discussion of using hormonal therapy beyond 10 years. What are the toxicities? I mean, we all know we have been using this. Vaginal complication, endometrial cancer, and thromboembolic phenomenon are sort of more common with TAM, whereas arthralgias, osteoporosis, and hot flushes are usually more common with the AIs. Does the story stop there? Well, it used to be the same thing for the last 20, 25 years, but now with the advent of CDK4/6 inhibitor, the panorama of treatment is changing. We have adjuvant CDK4/6 inhibitors. First, we got the approval for abemaciclib on the basis of Monarch E trial. I mean, not to delve into the details, but early stage breast cancer group, high risk, placebo versus abemaciclib, what we found out was that even the follow-up after 15, 19, 27 months, they tend to favor the patients receiving the abemaciclib and with a significant hazard ratio. Natalie, on the basis of Natalie trial, recently we got approval with adjuvant ribociclib, and we use it in a modified dose, 400 milligram for 2 years. Absolute benefit 3.1%, but I mean the curves are still separating. Long-term follow-up is still needed. Stage 2 and 3, I mean they tend to benefit more, but can be used earlier. So where do we stand? Neutropenia, liver toxicity, are sort of the most common with the QTC interval prolongation, side effects of the adjuvant CDK4/6 inhibitors, consistent with the data from the metastatic use of these CDK4/6 inhibitors. But in conclusion, endocrine therapies are safe, should be given, used in most of the patients who are ERP positive, HER2 negative. They can benefit more the patients if they're used with ovarian function suppression, and can be used for 10 years, should be used for 10 years, can be used alone, or we can switch from between TAM and AIs just to mitigate the type of toxicities we are getting. Abemaciclib, ribociclib have been added to the armamentarium and have benefit. But the question is, does everyone who meets the criteria of inclusion of Natalie on Monarch E trial, should all of them be given the adjuvant CDK4/6 inhibitors? I mean, you have to pick and choose the patient because there is a lot of cost involved. There's a lot of toxicity involved. So is this the optimal treatment regimen? Well, that is a discussion that still has to go on. Now coming to adjuvant chemotherapy, breast is a systemic disease, chemotherapy integral part. We start with the old concept, Halstead theory, just do the operation, remove as much as you can and leave it as such. But it was overturned by this brilliant person, Bernard Fisher, who was of the opinion that breast cancer is a systemic disease and should be treated as such. He is the man behind the NSABP trials, most of them. Then it was further, this discourse was further enhanced by Norton and Simon hypothesis, who sort of propagated that if you have smaller disease, they tend to be more aggressive. And if you give shorter durations chemotherapy, I mean, those dense chemotherapies, the patients may tend to do better. And this has proven to be true with a lot of trials. What is the data which support all these hypotheses? The first one, which showed the chemotherapy to be beneficial after adjuvant treatment, I mean, that was Bonadonna et al. In 1976, and he published the data from CMF. He published first just the data in 1976, and then he published a 30-year follow-up, and both showed that there was overall survival in the patients who received adjuvant chemotherapy, even though it was just CMF. It does not stop there. Then anthracycline became an integral part of the treatment regimen of adjuvant chemotherapy in the breast cancer. And the data is from a number of trials. I think the most pivotal one was NCIC MA5 and the French trial FASG05. You can see the overall survival around 5%, and p-value was significant. Then we added role of the paclitaxel to the already polychemotherapy arm, and the data came from CalGB 9344 trial, which showed overall survival 77% versus 80%, favoring the arm which used taxanes after the anthracyclines, and the p-value was significant. This is a wonderful slide. In my opinion, it just breaks you down and gives you all the important trials which led to the development of the polychemotherapy and where we stand right now. But it starts with Bonadonna et al., then NSABP B13, which established the role of polychemotherapy in the adjuvant setting in ER positive, HER2 negative, or in breast cancer as such. I mean, you can look at the last part of the slide, which can tell you the overall survival. I mean, this is pretty significant, 24% versus 47%, 74 versus 82%. Then it was followed by anthracycline-based chemotherapy. I mean, NCIC MA5, which showed you the benefit was 58% versus 62%, although p-value in this trial was not that significant. Then you have the establishment of AC followed by paclitaxel. The data came from 2 or 3 trials. The last one was CalGB 9741, which showed you 90 versus 92%, and p-value was significant. Then you have the dose-dense chemotherapy regimens, which evolved after BCIRG trials, which showed you a benefit of around 6%, p-value significant, and the PAX-01 trial. And then came the addition of docetaxel, which also was shown to enhance the response rates and overall survival with the usage of this drug in the adjuvant chemotherapy regimen. But do we stop there? Are the trials only enough? I mean, nothing in breast cancer is complete without the discussion of early breast cancer trialist group data. I mean, these guys have been doing wonderful job. They started early on in the 70s and 80s, and the first trial, the first established meta-analysis I could get my hands on was from 1988. And what it showed you was that there was 10-year improvement in survival of the patients who received chemotherapy if they were less than 50 years of age. The effect was more pronounced if they were ERPR negative, but still it was quite significant even though they were not, if they were ERPR positive, And if the nodal status came into the discussion, the results were much better of using chemotherapy regimens in these patients. Then in 2005, there were a number of trials which showed you in an early breast cancer trialist group data that if the patient has aged less than 50 years and used polychemotherapy, the benefit was around 9.9%. And if the age was 50 to 69%, the benefit also was there, though not that pronounced. 6% absolute benefit is still quite significant. Then the early breast cancer trialist group data of 2011, it showed you absolute gain of 6.5% by using different treatment regimens. I mean, anthracycline, this was based on anthracycline regimens, And if you used only CMF alone, the benefit was around 6.2%. Meta-analysis, which showed you in 2012 that if you used anthracycline-based regimen in place of CMF, the benefit was better. And if you used taxane, even the benefit was even more pronounced. To put it shortly, the first regimen line, which was CMF or AC into 4 or FACT, 50% dose, 35% reduction in the breast cancer mortality. And if you came to the second line regimens, which included FACT, AC4, T4, there was 20% reduction more as compared to the first line regimens. And if you came to the third lines, which was concurrent AC, DAC, TAC regimen, or the dose-dense regimen, the effect was more pronounced. The reduction was even 20% more. Neoadjuvant chemotherapy, why do we use it? We all know, we're all students of oncology. We know where we use it. If we were to pick 2 points, it was to downstage the disease, go for breast conservation as much as possible, and make the job easier for the surgeons. Do we have data to back that? Definitely. One of the trials, there was no statistically significant difference, but you can see that MRM was more if you used adjuvant chemotherapy, and breast conservation was more if neoadjuvant chemotherapy was used. And if you added docetaxel to the group on the basis of NSABP B27 trial, you can see the PCR is more, and the PCR can be a surrogate marker for improved overall survival, although there's still a discussion on that. Number of trials which tell you that survival is slightly better. If you used neoadjuvant chemotherapy in a slightly locally advanced disease, early breast cancer groups, 70 versus 69, 72 versus 67. Different trials, B18, the data from Royal Marsden, Institut Curie from France, all showing a slight improvement in the survival of the patients if the neoadjuvant chemotherapy regimen was used. And also, if you look at these trials again and look at the rate of breast conservation, you can see that the breast conservation is being favored by the use of neoadjuvant chemotherapy. Cochrane review, one-liner, no reasonably detectable difference between preoperative and post-operative chemotherapy in most of the patients who had ERPR positive, HER2 negative disease, but rates of breast conservation are better, surgery is easier, and breast conservation is really, really important when you talk to the female patients, But do we stop there? Well, we do not stop there. For a long period of time in ERPR positive tumors, it was just the chemotherapy. And we all know that chemotherapy was, ended up giving you response rates of around 15 to 20%, not more than that. But then we got 2 very good trials, the Keynote 756 and the Checkmate 7L, nivolumab and pembrolizumab being used in the neoadjuvant setting along with the chemotherapy. So what did the results show? They showed us that there is an improved in pathological complete response. The checkmate, unfortunately, was not designed to detect that. I mean, its primary endpoint was later on changed to include pathological complete response. Whereas in the keynote 756, it was designed in a way to detect the difference in pathological complete response. And what it showed was that in all the subgroup, the benefit was seen, but it was slightly more pronounced if they had higher PDL1 and they were ER-PR negative or had hormone positive disease. So in conclusion, neoadjuvant chemotherapy is slightly beneficial, more so in the patients who want to go for breast conservation therapy, and adding immunotherapy to the chemotherapy improves the pathological complete response, but does it decrease the risk of recurrence? I mean, we still have to wait for more data before we put this really expensive drug into the treatment regimen. Thank you all very much for your patient listening.
Thank you very much, Dr. Amjad. So our next presenter is Dr. Asghali. It will be a virtual presentation. She is clinical assistant professor at Cleveland Clinic Foundation in Cleveland, Ohio, United States of America, and she has the interest in breast cancer and has focused her research into clinical as well as translational research for breast cancer and management. So she'll be our next presenter. Thank you.
Hi, everyone. My name is Asghali. I'm an associate staff at Cleveland Clinic and assistant professor of medicine at Case Western Reserve University in Cleveland, Ohio. Today, I will be talking about ASCO 2024 updates in early breast cancer and biomarkers. These are my financial disclosures. For the talk here, I've picked 5 high-impact abstracts from ASCO 2024. These included the NATALEE trial node-negative patient analysis, AMH analysis from RxPonder, a BRAVE study, analysis on taxane-induced peripheral neuropathy, and ctDNA analysis and monarch-E. We will start with the NATALEE trial analysis. NATALEE trial, as we know, was a trial that included patients with HR-positive, HER2-negative early breast cancer. Patients included were anatomic stage 2 or 3. Node-negative patients were allowed, as demonstrated here. The trial randomized over 5,100 patients to ribociclib or non-steroidal aromatase inhibitor, NSAI or NSAI. Primary endpoints for IDFS, secondary endpoints for additional efficacy and safety endpoints, and then the trial also had exploratory endpoints. Just a quick review on the inclusion population for NATALEE versus monarch-E. As you can see, monarch-E largely included patients that were node positives. So N2s or N1s with an additional feature, which could be grade 3, a big tumor over 5 centimeters or more, Ki-67 greater than or equal to 20%. On the other hand, NATALEE allowed some early patients as well in terms of node negatives, as demonstrated here. So T2N0s had to have an additional feature, T3 and T4N0s were allowed, and it also allowed some N1s, which was not allowed on monarch-E. So this analysis is looking at these 3 subgroup of patients, so T2N0s, T3N0s, and T4N0s, which made up about 613 patients. In terms of characteristics, we see they're actually quite balanced. In terms of grade 2, majority, half of them were grade 2 and half of them were grade 3. 70-ish% of the patients were T2 stage. Half of them were grade 2 and grade 3 in terms of the grade. 70% of patients had prior neoadjuvant chemotherapy and 60% had prior estrogen blocker or endocrine therapy. In terms of the analysis, we see here, this is the node-negative group, invasive disease-free survival. Here shown is the DDFS or distant disease-free survival or distant relapse-free survival. And what we see is similar to the intention to treat population, if you guys recall. There was about a 3% benefit at 3 years, which is about very similar to what we see here. But I do want to draw your attention to the hazard ratio here and the wide confidence interval, which does cross 1. So that would predict lack of significance, as a matter of fact. Similar Similarly here, we see DDFS and DRFS, and once again, we see about a 3% absolute advantage, a hazard ratio, and a confidence interval that's really wide and crosses 1. Now, obviously, it should be noted that this is a subgroup analysis of a very small patient population, right? These are 600 or so patients from a 5,000 primary subgroup, and this is not a planned endpoint. So this data is not powered to predict significance. But the data is the data, and we have statistics because it is valuable. So we should probably proceed with interpreting this data with caution, but I think it's important to know that these values do cross 1. Now, in terms of adverse events, there is no unexpected safety signals. The rate of discontinuation in ribo plus NSAI arm is about 24%. In terms of side effects, we see what we typically see in clinic, which is about a 60% any grade neutropenia. We do see some liver toxicity on the study as we see in practice. There is some more QT prolongation with ribociclib versus NSAI. And interestingly, there's more arthralgia in the NSAI arm. Perhaps patients are just reporting it more in that group. So what do we learn from this analysis? That ribociclib plus NSAI showed a consistent IDFS and DRFS advantage in no-negative patient population enrolled on the NATALEE trial at 3 years. This is statistically not significant, although the number of patients is really small, survival data is immature, and this was not a pre-planned endpoint. And that's essentially what we just discussed. Next, we will talk about the AMH analysis in RxPonder patients. So RxPonder, as we recall, included both pre- and postmenopausal patients. Here, we're focusing on the premenopausal patients. Premenopausal women with HR-positive, HER2-negative breast cancer, 1 to 3 lymph nodes, and a recurrence score less than or equal to 25 were shown to derive chemotherapy benefit on RxPonder. It should also be noted that a very low number of women received ovarian function suppression on the study. And serum anti-Mullerian hormone is a measure of ovarian reserve. So the question is, should we use AMH or should that be a sensitive marker of ovarian function prediction or prediction of chemotherapy benefit? So what is the role of AMH in menopause? As you can see, the levels of AMH in the human body, they decline as one approaches menopause, with 0 here designating the final menstrual period or FMP, and then the number essentially stays low. FSH has a mild bump and then it plateaus out. LH has a mild bump, it plateaus out. We do see again in that in the graphic on the right here that the AMH essentially becomes undetectable around menopause and stays low. We also see that a lower age-specific AMH is correlated with an earlier risk of menopause. So what hormones and what levels are we expecting in menopause? We expect a low estradiol, progesterone, AMH, inhibin B, and high FSH and LH. So in this study, patients were older than 18, ER/PR positive, 1 to 3 lymph nodes, able to receive adjuvant chemotherapy. Recurrence score 0 to 25 are then randomized to receive chemotherapy followed by endocrine therapy versus endocrine therapy alone. What we see in the data is this is patients stratified by pre versus postmenopausal. By the way, premenopause was defined in the study, which was defined as age under 50 years or LMP less than 6 months. And what you see in these patients is that there's a 5.2% absolute 5-year IDFS advantage in the premenopausal patients. When you look at the postmenopausal patients, which were defined as LMP greater than 12 months or BSO, there's essentially no significant difference between chemotherapy, endocrine therapy versus endocrine therapy. What about chemotherapy benefit stratified by age? So if you see patients, we notice here that patients that are under 45 or 45 to 49 have a much more chemotherapy benefit versus 50 or older. Now we're going to see that those patient populations split up by AMH rather than age. So what do we know about AMH and its correlation with menopause and its levels? Low AMH is correlated with final menstrual period or FMP or later, and that's defined by less than 10 picograms per milliliters. Medium or high is defined as 10 to 99 or greater than 100 respectively. When we look at all the patients from RxPonder that were considered premenopausal, age under 45, there were 10 women that had low AMH, 45 to 49, there were 58, and age 50 to 54, there were 141. So the next few slides I'm about to show you is essentially data from these 10, 58, and 141 patients. We see here in terms of other variables like age, inhibin B, estradiol, progesterone, FSH, and estradiol and LH, only low AMH is the one that is significantly predictive of chemotherapy benefit or lack thereof. When, again, those women that I showed you, when you stratify them by low AMH, regardless of the age group, you see that there's no difference in 5-year IDFS. When you stratify them by median versus high, there's about a 7.8% improvement in 5-year IDFS with chemotherapy. In terms of distance relapse-free survival or DRFS, there's no difference in 5-year DRFS when you just look at the low AMH patients, again, regardless of their age. But with medium and high patients, regardless of their age, there's a 4.4% improvement in 5-year DRFS. So what have we learned from this analysis is that these patients that were premenopausal, under 55, 1 to 3 positive lymph nodes, recurrent score equal to or less than 25, 20.6% had a pretreatment serum AMH less than 10 picograms per milliliters, and these did not benefit from chemotherapy. Can AMH be a better predictor of adjuvant chemotherapy benefit compared to age, menopausal status, serum hormone levels alone? And can serum AMH predict who can safely forgo chemotherapy? And that's essentially what we just discussed. Next, we will talk about some data in the triple-negative patients. A-BRAVE was a phase 3 randomized study that included avelumab use in early-stage triple-negative breast cancer with residual disease after neoadjuvant or high risk of recurrence in the adjuvant setting. So this trial included a total of 466 triple-negative breast cancer patients, and patients were enrolled via 2 cohorts or 2 strata, if you will. Stratum A included patients that were about 18% of the total patient population. These were patients who had a biopsy, surgery, and then had adjuvant chemotherapy. And stratum B, which was majority of the patients, 82%, these were the ones that had a biopsy, neoadjuvant chemotherapy, surgery, and then adjuvant chemotherapy. Patients were then randomized to receive avelumab for 52 weeks versus observation. At the time of the study design, which was around 2015, chemotherapy was the standard of care. So therefore, we're not seeing a lot of neoadjuvant IO use here. Here's the entry criteria of the study. These are older than age 18 patients, ECOG 0 to 1, triple negative defined as ERPR less than 10%. These are the chemotherapy allowed, those are listed. And then once again, stratum A and stratum B, as we just discussed. In terms of patient characteristics, they are once again really balanced. Median age is 50 to 51. Here's the ERPR split up. HER2, majority of these patients were HER2 IHC 0, about 10% or so gBRCA mutated. A good split of stages 2 and 3. Majority of the residual disease patients were YPT1, and majority of the RCB, residual cancer burden patients, were RCB2. Now, adjuvant CAPE is a very low number of patients received adjuvant CAPE, 18 to 24%. And that, again, goes back to the timing of the design of the study. The CREATE-X had sort of come out during the time of the study enrollment. So therefore, the number of adjuvant CAPE is very low. The primary endpoints of A-BRAVE included DFS in intention to treat population and DFS in stratum B, which was the 82% of patients that I showed you. And what we see here is that while there's a trend towards improvement of DFS with avelumab, this is not statistically significant in the ITT population. And again, in the stratum B population, there's a trend towards benefit, but this is not statistically significant. What about secondary endpoints? So OS, we actually see a trend towards avelumab benefit and a statistically significant improvement in OS. And we also see a trend towards benefit and a statistically significant DDFS, which is a 7.5% reduction in favor of avelumab. So what do we learn from this? We see that non-statistically significant improvement in 3-year DFS with avelumab, which was the primary endpoint. There is statistically significant improvement in 3 years in OS and DDFS, but these are secondary and exploratory endpoints. So should we incorporate avelumab in the adjuvant setting? I think there's more to come on that. Jury is still out on that. I think this study does show a signal in the adjuvant setting in patients that don't have a tumor in place that we have not previously seen with some of the other studies. So I think it's an interesting option, but it is yet to see what we see from additional studies and from additional analyses. Next, we will talk about this analysis from this ECOG-Akron study on taxane-induced peripheral neuropathy, or TIPN. So this was a study designed for prospective validation of germline variants and taxane types in taxane-induced peripheral neuropathy, or TIPN, in Black women with early breast cancer. We know that Black women have poor outcomes in terms of disease course, drug toxicity, social determinants of health. The objective was to validate germline predictors of neuropathy, like SBF2 and FKMR, in these patients receiving taxane chemotherapy. So these patients are non-randomized, enrolled to cohort A, paclitaxel, or cohort B, docetaxel. And these are the primary endpoints, which is essentially prospective validation of the germline predictors I just showed you, and then comparison of neuropathy, comparison of dose reductions, and additional PRO and exploratory objectives. In terms of clinical characteristics, there were 126 patients stratified to the paclitaxel cohort and 123 stratified to docetaxel cohort. 70% or so of patients had BMI 30 or older. 51% or 43% in the other arm had stage 2 disease. Majority of these patients had A1C less than 6.5%, and majority of these patients were privately insured. In terms of variables, the only variable that correlates with grade 2 or more taxane-induced peripheral neuropathy is actually a high BMI. So it is important that high BMI is correlative of development of taxane-induced neuropathy in these patients. This is the primary endpoint that they had reported up front. So this looks sad. This is, by the way, very granular, so stay with me here. This is the high-risk patient, high-risk genes and the low-risk genes. And what we see here is the proportion of patients with grade 2 or higher taxane-induced peripheral neuropathy. So in the high-risk patients, which is these genes, the purple box, 38% had developed TIPN grade 2 or more, 47% versus 28%. So what you see is that more patients with paclitaxel developed neuropathy in the high-risk gene group. In the low-risk patients, once again, more patients in the paclitaxel arm developed neuropathy, but these values, if you compare 1-to-1, are lower in the low-risk versus high-risk groups. Now, what's interesting is that none of that really reached statistical significance. In terms of physician-educated TIPN or patient-reported TIPN, these were the secondary endpoints, if you recall. We see that there is a statistically significant lower incidence of docetaxel-associated peripheral neuropathy, both whether that's physician-educated or patient-reported TIPN. So primary endpoint of this is not met, as I showed you. There's higher rates of TIPN with high-risk genotypes, but then this did not reach statistical significance for validation. Every 3-week docetaxel is associated with less neuropathy, grade 2 or more, and dose reduction in Black patients, particularly in higher BMI patients. Last but not least, we'll talk about the ctDNA analysis in monarch-E. Monarch-E, as we briefly discussed earlier, this included patients that were primarily node positives, high-risk patients with early breast cancer. We had earlier seen the data at 5-year follow-up. There's a 33% relative risk reduction and an absolute 7.6% IDFS advantage and a 6.7% DRFS improvement. Aim of this analysis is to understand circulating tumor DNA or ctDNA dynamics. So monarch-E design, again, for review, patients were allowed to enroll via cohort 1 or cohort 2. Majority of the patients were enrolled through cohort 1. Patients were then randomized to a BEMA plus endocrine therapy versus endocrine therapy. And for this analysis, out of the 5,637 patients in the ITT population, patients were then sorted out based on the biomarker data availability and the whole exome sequencing data availability. And then the ctDNA cohort then included 910 patients. When you compare the ITT population and the ctDNA cohort, you see some similarities and some differences. For example, there is more adjuvant chemo in the ctDNA patient population in the adjuvant setting versus ITT patient population. The node status, the tumor grades, pathologic tumor size, it's all very similar. Patients in this cohort had blood collected at baseline, pre-dose 3 months, 6 months, and 12 months. The cohort was enriched for early IDFS events less than 24 months. So this is not an accurate representation, and we obviously know why that is, because we are trying to catch ctDNA dynamics, so it makes sense to catch the patients with recurrence events. So the IDFS event rate here is 27% versus 18% in the ITT population. Similar to ITT population, which is up here at the top, again, this is about 5,600 or so patients, and this is the ctDNA cohort down bottom, which is about 900 or so patients. We see a very similar gain and improvement in terms of IDFS. So there's an 80 to 86% gain versus 70 to 78.9% gain, both of them with significant p-values. In terms of ctDNA detection, this is where this all gets very granular. What we see here is that majority of the patients are ctDNA negative. This is 92% of patients, which is 840 patients. Baseline ctDNA positivity was in 8% of patients. This was 70 patients. Baseline ctDNA positive patients were 59% that remained positive, and baseline ctDNA negative patients, 10% became positive on treatment. Now, patients who are ctDNA positive or baseline were more likely to experience an IDFS event. So if you were baseline negative, the risk of you having an invasive disease-free survival event was 80%, the chance of not having an event. And that if you had baseline positivity, the incidence of that is 20%. Now, patients that were negative and remained negative, they were 14% likely to have an IDFS event. So these had the best survival, essentially. Patients that were baseline positive and remained positive, they were 100% likely to have an IDFS event. What about the ones that were baseline positive but remained negative, but became negative? So baseline positives that became negative had the second best IDFS improvement, which was a 42% likelihood of having an IDFS event. Those that were baseline negative and became positive, they were 93% likely to have an IDFS event, probably representing a resistant population. Now, this is a very interesting analysis in terms of the patterns of recurrence. What we see is that patients that were ctDNA positive at any time, which was 152 patients, the risk of them having a distant recurrence was much higher than those that were ctDNA negative. Interestingly, ctDNA positivity was not great at picking up local recurrence, so that's actually better represented in the negative patients. I think it's really important to note that of the ctDNA negative patients, 72% of these patients still had a distant recurrence. So these tests are by no means perfect. Now, the data was not, this was not a pre-planned endpoint, but they did report this lead time data. And what we see is patients that were baseline negative but became positive had the shortest lead time. So again, this possibly represents a resistance development in these patients. And this was followed by patients that were baseline positive and remained positive. Now, what do we learn from this? That ctDNA detection with Signatera assay, first of all, there were less than 10% patients at baseline with the detectable ctDNA, and there were 17% with detectable ctDNA at any time. ctDNA positivity was prognostic for worse outcomes, worse for those that remained positive, and ctDNA negative tend to develop more local, regional, contralateral compared to ctDNA positive. So in conclusion here, we saw the NATALEE trial node negative patient update with an improved 3-year IDFS, DRFS, similar to ITT population in node negative 613 patients. This was not statistically significant, although this was a subgroup analysis not powered for significance. AMH responder, we saw that 20% of premenopausal women with low AMH did not derive chemotherapy benefit. AMH may be a better predictor of chemotherapy benefit versus age or menopausal status alone. ABRAVE, we saw a non-significant improvement in DFS, but significant improvement in OS and DDFS at 3 years with evolumab in the adjuvant setting. 82% of these were post-neoadjuvant, and there was no prior IO. TIPN, we saw that there's higher risk genotypes, did not statistically correlate with higher rates of TIPN. There is suggestion that docetaxel may yield less neuropathy in Black patients. And finally, with ctDNA analysis, we saw that ctDNA detection is prognostic of worse outcomes, particularly those that were persistently positive or those that were negative and became positive. With that, I thank you for your attention, and I look forward to attending the live Q&A session. Thank you.
Thank you very much, Dr. Asghali. So our next presenter is Dr. Virginia Kaklamani, and she's a professor at University of Texas Health Sciences at Centennial, and she's also co-chair of Breast Cancer Symposium. That is the biggest cancer symposium for breast in San Antonio. And she also has more than 150 publications under her name. So our next presenter is Dr. Virginia. Thank you.
Presentation today, I'll talk about early stage triple negative breast cancer and the different treatment options for this disease. These are my disclosures. So we'll cover a few topics today: standard of care therapy for high-risk disease, how to de-escalate therapy in our low-risk patients, what are the downsides of giving immunotherapeutics for our patients, and then finally, how do we tackle residual disease? So let's start with our first option, how to treat high-risk triple-negative breast cancer. And here we have to talk about KEYNOTE-522. This is a pivotal trial looking at the addition of pembrolizumab to a backbone of chemotherapy that includes an anthracycline, a taxane, as well as carboplatin. This trial really established pembrolizumab as the standard of care. And as you can see in the most recent data, suggesting a pretty impressive absolute difference between the pembrolizumab and the placebo arms, favoring the pembrolizumab arm. But there are a couple of things to keep in mind. First of all, patients that had stage 2 disease ended up having better outcomes compared to patients with stage 3 disease, regardless of whether they achieved a pathologic complete response. Same thing was the case with node-negative versus node-positive disease. Patients with node-positive disease at presentation, regardless of PCR status, still had worse outcomes compared to patients with node-negative disease. And this is important because we tend to think of PCR as really the only factor that is important for outcomes, but initial presentation stage does play a big role. And then what do we do with adjuvant pembrolizumab? Well, the data is really hard to interpret because all patients on the trial that were randomized to pembrolizumab received adjuvant pembrolizumab. But if we look at the patients that achieved a PCR, there didn't seem to be a difference between the pembro and the non-pembro arm. So as long as they achieved a PCR, they had good outcomes, potentially suggesting that adjuvant pembrolizumab may not be needed for these patients. However, patients that did not achieve a PCR had a benefit from pembrolizumab, and so in those patients, we should consider continuing it post-surgery. Now, as far as distant recurrences, these were the majority of the first events that were seen. Patients developing brain metastases, that was a small number of patients, and there didn't seem to be a difference between the two arms. But what pembrolizumab mostly did was decrease the rate of distant recurrences. Now, in our high-risk patients, we're also going to be considering olaparib if those patients have germline BRCA mutations. Now, this is coming from the Olympia trial. This is a trial mostly in triple-negative breast cancer patients. Only 18% or so of patients had ER-positive disease. All these patients were germline BRCA1 or 2 positive. And in the patients that were triple-negative that had initial neoadjuvant therapy, if they did not achieve a PCR, they were eligible for olaparib. And so they received olaparib versus placebo. And as was seen, there was not only an improvement in disease-free survival, but also overall survival favoring the arm that received olaparib. These results really established olaparib as a standard of care option for high-risk triple-negative breast cancer patients that have a germline BRCA mutation. Now, as far as adverse events, olaparib increased nausea as well as cytopenias in our patients, but these were relatively manageable, and the majority of patients were able to continue on study. Also, there was no increase in the rate of myelodysplastic syndrome or acute myelocytic leukemia. So let's move on to the patients that don't have high-risk disease, and how do we potentially de-escalate therapy for those patients? Now, this is some data from the NeoTrip trial that tried to give a backbone of chemotherapy without an anthracycline, but also add atezolizumab for those patients. Now, patients after surgery received an anthracycline, but when we look at the results prior to surgery, as far as PCR, there was an improvement in PCR in the atezolizumab arm. Those patients did a little bit better, not significantly better, and most of that benefit seemed to be in the patients that had PD-L1 positive tumors. Now, another trial, the NeoPAC trial, also tried to avoid giving an anthracycline, at least in the neoadjuvant setting. And so patients here received carboplatin, docetaxel, as well as pembrolizumab. And what was seen here was that the patients that had node-negative disease, for example, if they had a PCR, they had an improvement in their outcomes. And again, it showed that in those patients, giving a backbone of chemotherapy without an anthracycline plus pembrolizumab may actually be beneficial, achieving pretty high rates of both BCR and RCB01. So definitely an option for some of our lower risk patients. Now, this trial led to the S2212 trial. This is an ongoing clinical trial looking at pembrolizumab in the neoadjuvant setting. Now, here there are two arms. The first arm is the KEYNOTE-522 arm with carboplatin, paclitaxel, doxorubicin, and cyclophosphamide and pembro. And then the second arm does not include the AC. It just gives the carboplatin and docetaxel. Now, post-surgery patients may continue their pembrolizumab, and they can get capecitabine or something else depending on the physician preferences. Now, this trial is going to be important because it's going to tell us whether we can potentially avoid the AC part of our neoadjuvant therapy. Now, something else that's extremely important is the presence of TILs. There was a recent study that looked at whether patients' tumors had tumor-infiltrating lymphocytes or not. And it showed that patients that had tumors with high levels of TILs had excellent prognosis, even if they did not receive any chemotherapy. And this is extremely important because we don't tend to avoid chemotherapy in these patients, but maybe we should. Maybe we should not be giving chemotherapy to patients that may potentially not benefit from it. And some of these patients we have that have low-risk disease, and that may be the case with patients that have high levels of TILs, may be the patients that we can help avoid giving chemotherapy to. So let's look at another important aspect, and this is the downsides of immunotherapeutics. Now, we've been giving immunotherapeutics in many cancers, including breast cancer, for a long time, but we know the patients that receive immunotherapy have several both acute and long-term toxicities. So let's look at some of those chronic immune-related adverse events. They can have musculoskeletal events such as myasthenia gravis and Guillain-Barré. They can have vitiligo. They can have ocular toxicity. Those tend to be toxicities that in most cases, they will be chronic. We know that hypothyroidism and hypophysitis, those are permanent events. So once a patient develops that, they will have to live with that for the rest of their lives, including adrenal insufficiency. So this is something that we have to discuss with our patients. This is something that we also have to think about because these patients may have several of these adverse events. And there was some data presented late last year at the San Antonio Breast Cancer Symposium as far as real-world data from patients receiving the 522 regimen. Interestingly, pathologic complete response was lower than what was seen in the 522 trial. Around 55% of patients had pathologic CR, whereas in 522, 65% of patients had pathologic complete response. Also, the adverse reactions were more. Grade 3 or more immune-related adverse events were seen in around 30% of patients, and hospitalization rates in 35% of patients. Acute care utilization in 38% of patients. So when comparing the retrospective cohorts with what was seen in KEYNOTE-522, what we can see is that there's a higher rate of early discontinuation and a higher rate of immune-related adverse events. And this is, again, important because we know that our clinical trials are scrutinized as far as the patient population that they can include. And so when we look at the patients and the patient that we have in front of us, we have to be thinking about really real-world data and what is this patient compared to the patient that was included in Keynote 522. So moving on to our last question, and this is how do we tackle residual disease? And this is really an unmet need when it comes to early stage triple negative breast cancer. So we've had the CREATE-X trial. This is a trial that was done in Japan, looking at patients that had a non-pathologic CR with neoadjuvant chemotherapy. These patients were randomized to either receive standard therapy, which was nothing, or standard therapy plus capecitabine. And as we all know, patients had an improvement not only in distant disease-free survival, but also overall survival, favoring the arm that received pembrolizumab, capecitabine. And again, this is important because this really changed how we see these patients and how we treat them. But interestingly, there was some data coming out of a Spanish group showing that potentially the patients that are going to benefit from capecitabine are the patients that have non-basal triple negative breast cancer. As you can see here, the patients with basal breast cancer did not have any benefit from the addition of capecitabine in the adjuvant setting, but the patients with non-basal disease were the ones that had a benefit. And in practice, we don't look at that. We don't look at the subtype of breast cancer, triple negative breast cancer that patients have. We typically just give capecitabine to all of our patients, but this makes us wonder whether we should be looking at subtype of triple negative breast cancer. And to go a step further, we can look at the ECOG 1131 trial. This was a phase 3 clinical trial in patients that met the criteria for CREATE-X. They did not have a pathologic CR with neoadjuvant chemotherapy. So these patients were randomized to either receive capecitabine, which was considered standard of care based on CREATE-X, or receive a platinum agent. And what was seen was, first of all, the patients that had basal disease did worse compared to the patients that did not have basal disease, although both patient populations did not do very well. But also, it showed that the patients that had basal disease did not benefit from therapy. Patients that had basal disease did not benefit from either of the two therapies, whereas the patients that had non-basal disease may have benefited a little more from capecitabine. So this also tells us that yet another second study suggesting that we should potentially be looking at basal versus non-basal. And in the patients with basal disease, capecitabine or platinum agents are not going to help improve their outcomes. So what should we do in the future? How can we help improve outcomes in the future? And here there's been a lot of excitement about minimal residual disease. We have now assays that are looking at ctDNA, circulating ctDNA, or circulating tumor cells. And many of these studies have shown that these assays are prognostic. You can see here several examples looking at CTCs and ctDNA, showing that if a patient has detected ctDNA, they have worse outcomes compared to patients that do not have detected ctDNA. So how can we do something? And here the NTRAC trial tried to answer this question. So this was a trial looking at early stage triple negative breast cancer patients, received neoadjuvant chemotherapy, had residual disease. And so then they looked at this ctDNA assay. And they also had active ctDNA surveillance. And so what they did was they randomized the patients to an intervention, which at that point was pembrolizumab, or observation. Obviously, the patients had staging, and the whole point was that the staging scans were negative, even though the patients had positive ctDNA. So again, this was a small trial, but this was interesting. First of all, 4 out of 5 patients that started treatment in the ctDNA treatment group with pembrolizumab had to discontinue therapy. 3 of them because of recurrence, and 1 because of adverse events. 1 patient continued on treatment. No patient exhibited sustained ctDNA clearance at 6 months after starting pembrolizumab. So pembrolizumab was not able to diminish the amount of ctDNA. And then what was also pretty discouraging was the fact that once that ctDNA was positive and patients had scans, 72% of those patients had overt metastatic disease. And so by the time that ctDNA was detected, it was too late to be able to help prevent the development of metastatic disease in 72% of patients. Then in the observation group, so patients that did not receive any therapy, 4 patients continued to be recurrence-free. All of those 4 patients became ctDNA negative, even though their initial ctDNA was positive. So, and then 2 of those patients became ctDNA positive again. So it's really unclear what this ctDNA is going to do over time. And it's also unclear whether there's specific treatments that we can recommend to our patients to try to minimize and hopefully eradicate that ctDNA and prevent the development of metastatic disease. So now there are personalized MRD assays, and some of them are actually approved by Medicare in the United States. So patients are coming and asking for them. One of these studies you can see here looking at ctDNA status, and you can see here that if a patient had a negative ctDNA, they had a much better prognosis compared to patients that had a positive ctDNA. Now, the majority of these patients on the trial were patients with HR-positive disease, but there were patients with triple-negative breast cancer as well. Relapse was seen at around 8.9 months, but this was not a study where patients had serial CT scans. Patients had the MRD assay done, and then they only had CT scans at the time of symptoms. So there definitely was a lag time between the development of metastatic disease and the development of symptoms that led to CT scan. So this 8.9 months is likely not very accurate. And these studies led to the Persevere trial. This was a study in patients with triple-negative breast cancer that had residual disease. They looked at plasma ctDNA. If this was negative, patients had treatment of physician's choice, likely capecitabine. And if it was positive, they looked at the genomic characteristics of that ctDNA. And if the ctDNA did not have any genomic target, then they received standard of care therapy. But if they did have a genomic target, which, for example, may have been in the DNA repair pathway, they could have received a PARP inhibitor, immune therapy pathway, they could have received immune therapy and so forth to try to really decrease the amount of metastatic disease or prevent metastatic disease. Unfortunately, there was very low rate of ctDNA detected after surgery. And so the study is currently on hold. We're still working through the statistics to see whether there's something else we can do to salvage the trial. But this is, again, pretty discouraging because this sort of study is going to show us whether we can use minimal residual disease, not just for prognostic reasons, but also for predictive reasons. So this is my treatment algorithm for patients with early stage triple-negative breast cancer. If they have stage 1 disease, the majority of these patients will go to surgery and then likely receive adjuvant chemotherapy. But there is a patient subset, the patients with T1C disease, that may potentially benefit from neoadjuvant therapy. And here's where we want to use some sort of de-escalation treatment, maybe part of the Keynote 522 trial to try to get these patients to PCR. In patients that have a higher risk disease, stage 2 or stage 3, we're going to use the Keynote 522 regimen. I think this is considered standard of care now. If they have pathologic complete response, they can continue with immunotherapy, even though you can make an argument to stop pembrolizumab as well. If they don't have PCR, then we look at BRCA status. If their BRCA status is positive, then we should consider olaparib for a year. And I also continue the pembrolizumab as well. The BRCA negative, then I would urge you to try to find a clinical trial for those patients. I think it's extremely important that we discuss clinical trials with them. But if we don't have a clinical trial available, then capecitabine should probably be our option of choice, as well as continuation of the pembrolizumab. So maybe some of my conclusions. I think Keynote 522 is considered standard of care for our high-risk patients, but can we de-escalate? If there's a good initial response, do we need to give the anthracycline to all of these patients? What do we do if the tumor is rich in TILs? We know that these patients have better prognosis. Does everybody need immunotherapy? Probably not. Are there some biomarkers that we can use? Do we need to continue adjuvant immunotherapy? There's clinical trials that are going to address that, but for now, the only trial that we had continued immunotherapy in the adjuvant setting. We need to consider that IO is not benign, that it can have toxicities, and those toxicities can lead to hospitalizations in more than 30% of patients. So we have to be very careful. And we're still struggling with what to do with residual disease. The MRD assays are still pretty premature to use as standard of care options. We know that they're prognostic, but we don't know that they're predictive. And so it's important that we don't routinely do them, but we only do them during while a patient is on a clinical trial. So I want to thank you so much for inviting me again. It's truly an honor, and I hope you've enjoyed this presentation. Thank you.
Thank you very much, Dr. Virginia. So I would like to invite Dr. Azhar Shafiq for our question and answer session. Please, if you can come up to the stage, as well as Dr. Abdullah Bukhari, who happens to be co-chair for our symposium. Thank you. So if anybody can have any questions, they can ask questions now. Or we also have some virtual questions. So first question is for Dr. Amjad. Question is in regards to oncotype DX recurrence score in patients who have a lymph node 1 or 2 positive disease are now premenopausal. With this given data, as an oncologist, do you feel comfortable not offering these patients adjuvant chemo if oncotype DX recurrence score is less than 25?
I mean, it will depend upon the age of the patient as well. If the patient is young and the score is, let's say, around from 15 to 25, I hope that is what we're talking about. Because less than 15, it's hormonal therapy, and we have established that with our Tilarex and RX bonded both. But it's hormone positive and 15 to 25, age less than 50, probably I would go for chemotherapy in that subgroup. Although the benefit is around 15 to 20%, but I mean, that's quite significant. And just leaving it to chance or just leaving it to ovarian function suppression on the basis of data we have, I'm not really sure I would be safe doing that. So I would rather treat sort of over treat a bit than leave it to chance or fate, because if the patient is young and the survival is like 22 to 3 decades, and not offering a chemotherapy, I think it adds to the risk.
That's interesting because I think it's obviously it's not clear at this time. We even don't have approval for oncotype DX recurrence score in this setting anyways to even utilize for all of our patients. But even NCCN guidelines include this as it could be an option that could be considered. But I think it's difficult to forego chemotherapy for our patients who are so young.
Absolutely, especially if it's a young patient.
So next question I have for Dr. Abdullah Bukhari. So the question is, like these days, since we have been talking about a lot about adjuvant, let's say abemaciclib or ribociclib for our patients based on different clinical trials. So if a patient has completed 2 years of ribociclib, let's say a patient recurs within a year, so what's your next line of option?
Well, that's a very good question, Dr. Zishan. And the bottom line of the answer is that we don't know. The reason being we don't have any evidence as to what we should be doing if someone progresses after adjuvant abemaciclib. But now there are some trials in which we know that if we change the CDK4/6 inhibitors from ribociclib on progression to abemaciclib, then we do have some evidence that we can do it. But in that trial, the ribociclib was used in metastatic setting rather than adjuvant setting. So I believe that we will have to probably extrapolate the data from that trial. And if the patient progresses on adjuvant ribociclib, then probably switch it to abemaciclib.
Thank you very much. So I have another question for Dr. Azhar Shafi. The question is for triple negative patients who have received, personally, I think is obviously heavily treated with neoadjuvant chemotherapy, AC, then carboplatin, Taxol, then with let's say with pembrolizumab, and after that, if they have residual disease, we offer them Xeloda. The question is, are we overtreating our patients? So I can repeat the question. Question is for triple negative preoperative settings. We are offering our patients AC with Keytruda and then carboplatin Taxol with Keytruda, followed by like Xeloda if patient has if patient has residual disease. So the question is, are we over treating our patients because these are two different clinical trials? First, they happen to identify the need for preoperative Keytruda. That was a different trial. And then they defined all those patients who had residual disease that they will benefit from Xeloda or capecitabine. The question is, in our population, can we combine all this treatment for one patient where in all the research or clinical trials, I don't think we have any data to support that. So in your practice, what do you do then?
No, we don't have that because the CREATE-X trial, the use of adjuvant Xeloda, as I know, was much, much before the Keynote trial. So we cannot apply on that. If we have a patient who, as is mentioned in the last presentation, who does not achieve a complete pathological response, we have to continue. Regardless of, like the standard of care right now is, if you have a complete pathological response, you need to continue with immunotherapy for 1 year, complete. But should we combine this with Xeloda or not? I don't think so. That would be the added toxicity. The way we are using in Xeloda in our practice is most of the patients who are triple negative is even the stage 2 patients, most of that was studied in stage 2 patients, is because of the cost concerns. In fact, the patients who did not get to any immunotherapy at all. I think that CREATE-X was applicable in that particular population in which the immunotherapy was not given.
Okay, thank you very much. Any other questions?
Can I add as well?
Sure.
So as Dr. Azhar Shafi said, that there is no evidence behind it, and I don't think we are going to get any evidence in the near future. And this question is being raised in quite a lot of conferences as to what we should be doing if a patient has residual disease after neoadjuvant chemotherapy and pembrolizumab. Should we add capecitabine in adjuvant setting along with pembro, which was the actual question. So majority of the clinicians are doing it. There is no evidence behind it, as Dr. Azhar Shafi said, but majority of the physicians and experts, they are doing it. And they have not raised any extra safety concerns regarding it.
Thank you.
But this is an evidence-free zone. So whatever we do is right.
My name is Zahir Abbas. I'm a clinical oncologist here. I have a question from Dr. Azhar. So you talked about de-escalation. So my question is regarding adjuvant settings, HER2-positive patients who are node negative and T1. So in adjuvant setting, they would get HER2-directed treatment like Herceptin. Is it mandatory to combine it with the chemotherapy, or can we de-escalate in node negative patients who are T1? Sometimes performance status is borderline, and we just have to combine chemotherapy just for the sake of fulfill the criteria. So in your practice, what you do, that's one question. And I have another question. So you talked about drug and antibody conjugates in neoadjuvant setting. So there's a lot of data in the metastatic setting, but do you have any knowledge or any experience that these drug antibody conjugates will be available in the neoadjuvant setting in low HER2 positive patients?
Right. So I didn't get the first part of the question right. I'll answer first the second part. See, the way we are right now, we are still struggling with getting our patients to Kadcyla, which is like a TDM1, even for the residual patients, because as we know that the cost is a big factor. So Of course, there is an emerging data. That's all. The de-escalation theme is based on preserving the quality of life for early breast cancer patients and sparing them from long-term toxicity. See, even if you, what is the minimum chemotherapy backbone you use? Is a taxane, like in APT trial, you just do single-agent paclitaxel. But if you see, even if you use 12 cycles of single-agent paclitaxel, there is a significant number of patients who would have neuropathy, which may not settle all their life. But currently, see, this is all in trial, as we said, attempt two, maybe, but the currently first, of course, this is not FDA approved, and second, of course, here, I think it will take us a very, very long time for this drug to until and unless we get the socioeconomics right or we have some approval. Overall, where we stand, I think we have great difficulty in giving it even in patients who did not get to PCR. And the first part of your question, I didn't get it right. Mic doesn't work.
First question, in adjuvant setting, if they're T1 or negative early stage cancers, so they haven't got anything in the neoadjuvant setting. But if we give them adjuvant chemotherapy, adjuvant HER2 based treatment, so can we avoid in patients who have borderline performance status giving any chemotherapy, and we can only proceed with Herceptin or HER2 directed treatment in T1 node negative HER2 positive patients?
No. So currently we do not have any data using single agent, just Herceptin or trastuzumab. Right now, we do not have. Even for, say, we talked about a very low risk group, node negative, T1A, T1B. We do not have any data of using just Herceptin, single agent Herceptin without the minimal chemotherapy backbone has been at least paclitaxel, like in APT trial.
And the second question was about...
It may be like the last one, but that is investigational and it will come. Like if you are applying HER2-DX assay and there is a subgroup of patients, node negative, small, because see, HER2-DX assays raise some other serious questions that the recurrence risk and the PCR probability in the DEFIN trial was independent of TNM stage. So that shows the intrinsic behavior of the tumor. So maybe if we have more trials, more data, then maybe we will be able to better identify patients with confidence. Like, you see the conflict in NCCN recommendation, stage 1A, stage 1B. So whether to give them any systemic treatment or not, that should be another question. If you have a very low risk group like T1A, T1B, and this patient is like node negative, but that will be probably guided by the genomic assay. Currently, we have uncertainty, and because of the high risk of recurrence head-to-head with the other, we end up giving them. But the basic answer is no, we don't have any data for single-agent trastuzumab. Thank you.
Assalamu alaikum. My name is Farwa. I'm an oncology nurse from Tertiary Care. I have a very basic question for my personal knowledge. I want to ask if a female have a body potential of developing fibroadenomas again and again. So do we need to remove surgically it again, or let it be and monitor aggressively to it? I'm asking this question because if we will take history from the patients, the basic starts from that because they are ignoring fibroadenomas and they will develop after 2 to 3 years. They will develop into a malignant cells.
Well, frankly, if you're quite sure and so your sonologist is quite good and they're quite confident that it's a fibroadenoma,
yes,
I don't think you need repeated surgeries at all.
Okay.
But I mean, if there is an element of suspicion or a doubt, then definitely you have to go for a proper assessment and probably refer to a surgeon. But if they're quite confident it's a fibroadenoma, I don't think there is any guideline which tells you that go for repeated resections,
So, sir, how many chances the fibroadenomas convert into a malignant cells?
Well, true fibroadenomas rarely very, 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 very rarely convert into anything other than the fibroadenoma itself, So very, very low.
Okay, thank you. Thank you so much.
Asanko. I'm Dr. Aisha, a fellow breast surgery. I just want to ask a question. In the patient with the triple negative disease and the HER2 positive patient, so we know we have to give the chemo at some stage, either we give them neoadjuvant and adjuvant. So for the early stage breast cancer, especially T1 and early T2 cancers, I just want to ask which is more beneficial for the patient. Should we go for the neoadjuvant setting, or we should give the chemo in the adjuvant one, especially if the tumor is 1 centimeter or 2 centimeter? So in the MDTs, usually this is the question that we usually ask, like, what is the more, like oncologists usually suggest us that we should go for the upfront surgery, but it's a triple negative and patient has to take the chemo. So as a surgeon, we should give the chemo first, and then the patient should downstage and then go for the surgery. So it is actually the more beneficial than any data we have.
As per current guidelines, ASMO and NCCN both, they recommend that if you have a T2 or more advanced disease, T2 and 0 or above, in both triple negative and HER2 positive, you have to go for neoadjuvant. That is as per current data. If it is less than that, it is your choice. You can choose. But if it's T2 or more, then you definitely have to give that patient neoadjuvant chemotherapy. That is as per my knowledge. And that is as per the St. Gallen's consensus, ASCO, NCCN, and the ASMO as well, I'd like to add anything.
I completely agree with Dr. Amjad. But we also have to look at the patient characteristics of the data from the adjuvant settings. And if I remember correctly, in the Catherine trial, I think around 15 to 20% of the patients were 1 to 2 centimeters in tumor size. So that essentially means that these patients initially had a tumor of 1 to 2 centimeters, and then they were given neoadjuvant chemotherapy, and then they had residual disease. And then on the basis of residual disease, your treatment completely changes. And that is exactly the same case with triple negative breast cancer as well, that if there is residual disease, your treatment completely changes. So like, let's say if you've got a young patient, with a tumor size of somewhere around 1.5, 1.4 centimeters, and you know that you have to give this patient chemotherapy, I would rather give it in neoadjuvant setting rather than in adjuvant setting. It doesn't make too much difference to us in hormone receptor positive breast cancer patients, because the treatment essentially does not change after neoadjuvant chemotherapy. But in triple negatives and HER2 positive, the adjuvant treatment changes. So as I said, it is a physician discretion, but somewhere around 1.5 centimeters, I would be more inclined for neoadjuvant.
I just have a comment. I think as from oncologist perspective, especially for HER2 positive and triple negatives, I'm more inclined towards neoadjuvant approach. The reason is in the community, we keep on getting, especially where I work in a private setup, and we do not have any eligibility criteria like we have in Shaukat Khanum. So you end up getting patients who have lumpectomy with absolutely inadequate axillary staging, even if they're HER2 or HER2 positive or triple negative. So this puts you in two dilemmas. Number one, you do not have adequate axillary staging. Number two, you are not sure about the margins and what to do with them. So this practice, as I said, that the knife has an edge to get to the patient all the time. So is it possible? So new adjuvant approach and discussion MDT after especially the true cut biopsy, I think it's mandatory. Otherwise, we keep on facing these two dilemmas: inadequate axillary staging and the margin status after lumpectomy, because you are really in trouble after this. Even if you do imaging, you're never sure, especially if done in the peripheral settings. Thank you.
Thank you very much. So thank you for your presence and for your time. So it's a Juma prayer break, so we'll come back later. So thank you very much again.